Good afternoon, everyone. We'd like to welcome you all to today's Beehive webinar series. We're grateful for all who have chosen to attend today, schedules permitting. We'd like to remind you that all attendees are in listen-only mode, and we would encourage you, if you have any questions, to ask those questions in the toolbar through GoToMeeting, and send those questions to us, and we will answer them as we receive them. So please push your questions our way. We want to remind you that today's webinar is being recorded and will be available to watch mid next week. We are excited to be spending some time with you today. Before we start today's presentation and move into things, we'd quickly like to highlight the Beehive services that are available to all of our clients. If there are any services here that you have questions regarding, we'd like to invite you to reach out and talk to one of our team members, account manager or producer, with any questions you have regarding those. Specifically, and in light of today's topic concerning COVID-19, we'd like to highlight telehealth. Telehealth is a great resource. I use it often for me and my family. I've got my wife and 4 kids on the plan, and it's nice to be able to reach out to a doctor any time of the day or night, 7 days a week, and be able to have many of our questions answered that we would generally go into the doctor for. It's a great service. So again, as you guys have questions, please push them back to us regarding any of these services. Today, our sponsor will be Regence Blue Cross Blue Shield, and we are grateful for Regence. We are thankful for our partnership with them, and 2 of the team members that will be joining us today from Regence Blue Cross Blue Shield are Amy Jenkins and Dr. Amy Kahn. We're grateful for their participation in today's webinar and are looking forward to the content that they will provide. Amy Jenkins will be helping to field questions that come in, and we'll push those to Dr. Kahn. I will also turn over some time here shortly to Amy to introduce and talk through some of the benefits of Regence and make the introduction to Dr. Amy Kahn. So without further ado, Amy Jenkins, the floor is yours.
Perfect. Thank you, Spencer, so much for that introduction. I so value our relationship that we have with Beehive. They are such an amazing team. You guys can all be rest assured you are in good hands working with them, regardless of which carrier you're with. I'd like to just take a couple of minutes and just highlight some of the things that are so great about Regence, and ask you to maybe consider taking a look at why we'd be such a good fit for you. As of course, you'll want to work through Beehive to explore that further as your renewals come up. So Regence is actually powered by Blue Cross Blue Shield. And I imagine most of you are pretty familiar with that symbol. It's one of the most trusted and recognized symbols in the country. You can be assured when you present that insurance card at your doctor's office, they're going to recognize it. They're going to know exactly what to do with your claims and know how we will pay the claim for the doctor. As a Regence plan member, you would join 3 million others at a company that is 100+ years strong, and we're made up of nonprofit health plans. So, and then additionally, nationwide, 1 in 3 Americans carry a Blue Cross Blue Shield card. So whether you want a plan that you can get to provide access to top doctors and facilities throughout the entire country and the world, or maybe you're just looking for some coordinated network coverage here in Utah, we can offer you a health insurance plan that's tailored to your health, your budget, and your lifestyle. Regence offers plans with head-to-toe coverage, no cost in-network preventive care, and you can ensure you'll be able to receive the right care at the right time and at the right place. We also have member-only discounts on lots of health-related products. Some examples would be gym memberships, LASIK, allergy supplies, weight management. That's just to name a few of them, for example. So you can easily manage your health with the Regence app, or at regence.com. You're able to see claims, benefits. You can find network doctors, estimate costs of treatment, chat live with customer service, and so much more is available out on our website. So we would love the opportunity to explore why we'd be a good fit for you. I appreciate you giving me a few minutes of your time today, and we will start into the meat of things here. But I would like to just take one moment to introduce Dr. Khan to you guys. She has been such an invaluable addition at the Regence plan here in Utah. She, aside from just being a great presenter and a joy to be around, she has such a strong background that helps provide us the support and the support to our clients that they need around clinical services. So Dr. Khan is, her official role here at Regence is the medical director for Regence Blue Cross Blue Shield of Utah. She has extensive experience in population health, coordinated care management, and developing high-performance provider networks. Dr. Khan leads medical cost and quality stewardship activities for Regence. She spent 15 years in clinical practice where she focused on internal medicine, addiction medicine, and chronic disease prevention. On behalf of Regence and its members, she advocates for value-based care and drives strategic alignment with providers to achieve person-focused care transformation. She received her Doctor of Medicine from Wayne State University of Medicine in Detroit, and Master of Public Health from Johns Hopkins Bloomberg School of Public Health in Baltimore. She completed her internal medicine residency at Kaiser Foundation Hospital and her public health and general preventive medicine residency at the Centers for Disease Control and Prevention, where she also served as an officer in the Epidemic Intelligence Service. So without further ado, I'm so pleased to announce Dr. Khan with our COVID-19 updates. Thanks so much.
Well, thank you so much, Amy, for that kind introduction, and Spencer for the opportunity to join you and others today. Really excited to kind of share a little bit more about what we're all living through this extraordinary time, right, with COVID-19, a pandemic, and now, well, almost 9 months into it. And I do know that there's that chat feature. So Amy, I know, is going to man that for us and let me know if there's questions. I really hope this can be interactive. My hope today is that you'll leave with perhaps a few of your own questions answered and gain a little bit more knowledge about COVID-19 and what we need to be doing to continue to protect ourselves and others as we continue to learn more about this. So I am going to show you the presentation from my workstation here. So here we go. And let's see here. Get on to the slideshow. Excellent. So I'm going to go over the COVID basics, if you will, about COVID-19. I'll spend a little time talking with you about our immune response. It's something I think we've all needed to pay attention to because with the arrival of this novel virus, everyone sort of responds to it differently. Some of us have more likely to have a more severe infection than others, and I think it's helpful for everybody to understand sort of what might be happening should you become infected with this particular infection. We'll talk about the importance of COVID-19 testing, and in particular, this concept of contact tracing, again, to sort of stop the virus from propagating across the community. I'll talk a little bit more about prevention, what we can do today and what we're looking forward to as it relates to a potential vaccine in the near future. And then ultimately, again, steps we can take to reduce transmission and what treatment is available now and what we might be looking for. Again, really hope we'll have some good questions, maybe some good dialogue here as we continue to explore this topic together. So jumping right in, did want to share that this picture on the left is an electron microscope picture. It's actually from the CDC and represents our first patient in the US and really demonstrates this round RNA virus in these sort of rounded vesicles, if you will, with these spots on it that represents the nucleic acid invading a human cell. And keep in mind that this particular infection was first identified at the end of 2019. It was called the SARS-CoV-2 virus. And because it was in 2019, we called this coronavirus disease 2019. For short, we call it COVID-19. This is a type of coronavirus which was felt to be a zoonotic infection. What that means is that the natural reservoir was an animal, not a human. And so for 100% of us on the planet, nobody, no human had any immunity to this particular virus. What's important to really note is that in the 9 months that we've been all living with this, it's spread around the globe and affected over 32 million people. In the US, we're approaching 7 million infections, and we've just crossed over 200,000 deaths. The transmission is felt to be person to person through infected viral secretions, if you will, so respiratory secretions that have this virus in it. And it's quite plausible, perhaps, but not as likely that it could be spread through contaminated surfaces. So that means if someone sneezed onto a counter, another person unknowingly, unwittingly could come by, touch that surface of that contaminated secretion, and then touch their eyes, nose, or mouth, and thereby infect themselves. The main way that this virus gains entry into our body is through the spike protein on the virus. You've probably seen some of the cartoons or pictures of the virus that have these little spikes on it. That spike is felt to latch onto a certain receptor of a cell that lines our respiratory tract and then gains entry, if you will, into humans to set up infection. This particular infection has an incubation period of 2 to 14 days. That's the range, but the average individual who becomes infected will have an incubation period about 4 to 5 days. And keep in mind that individuals who are infected can be asymptomatic, or they are able to spread virus or shed virus 2 days before they may have symptoms. Well, what kind of symptoms do we think about? Fever, dry cough. Some might have shortness of breath. There may be some aching, similar to an overall viral illness. What is a little bit unusual is that many persons report the loss of taste and the loss of smell, and it can be fairly profound. So it might be a clue, if you will, that person's infected. Fortunately, the majority of people do not have serious illness. About 80% will have mild illness or really no symptoms whatsoever. About 20%, though, will have significant infection to the point that they seek care from their doctor, go to the emergency department. About 15%, it'll be moderate. They need to monitor their support that's available. They're unlikely to, need intensive care, but for a smaller portion of the people infected, about 1 out of 20, those individuals will need to be hospitalized. Many will require intensive care, and a number will go on to have life-threatening illness requiring mechanical ventilation and potentially succumb to this disease. Now, we know that not everyone has an equal risk for severe infection, and it is more likely to have more severe infection the older you are. Right? The older generation, the older persons, when I say older, what I'm saying is over 65, are more likely to have more serious illness, more likely to be hospitalized or die. But there are other individuals that really have risks, and I'll show you that in just a second. I did want to mention for sure that people who live in group homes or are in domiciles where there might be number of like dorms, if you will, or assisted living, skilled nursing facilities, incarcerated persons who are living in close proximity, that is an environment that puts those individuals at greater risk. And we'll talk a little bit about how density can impact the likelihood that this infection can spread. And then lastly, just a call out to our essential workers. Now, whether that's a healthcare worker or someone who's making your food or delivering food, these are folks that are really in the front line and are more likely to have more exposures to people who might be infected, so that puts them at greater risk for infection. So let's take a look at the health disparities that we know are legion among this virus and infection. And these are data from Utah. On the left side of this exhibit, you'll see a bar chart. And the green bars are to reflect the proportion of that race or ethnic group within Utah. And the lighter blue bars are the proportion of cases that are represented in that group. So very quickly, I've highlighted for you that Hispanic or Latino persons, although they represent only 14% of our population, they represent a third of our overall COVID-19 cases. Similarly, among Pacific Islanders, of which about 2% of our population are Pacific Islanders in Utah, they represent 4% of the cases. So again, demonstrating some of these disparities. Now, the highest test positivity rate, right, is among these ethnic minorities. And part of that is because these are individuals that may be less likely to have access to testing, right, than, let's say, the white non-Hispanic group in our population. I'd also call out the data on the right side of this slide, which shows the rate of hospitalizations across these race and ethnic groups. And what you can see is that the American Indian Native population has a very high rate of infection per 1,000 members, as well as Pacific Islanders compared to the other ethnic groups. But all the other ethnic groups, race groups denoted here, are higher than the white non-Hispanic group. And again, keep in mind that when we look at mortality rates are disproportionately higher among Native American, American Indian, and Pacific Islanders in Utah. And there are a number of reasons for this that really extend beyond the actual race ethnicity, have a lot to do with our health inequity, access to care, underlying health risks when it comes to chronic conditions. So speaking of these chronic conditions, I thought it would be helpful to review for you what are sort of risk conditions that if you have these conditions, you may be more likely to have more severe COVID that might require hospitalizations. And again, these are data from Utah, and it says that 1 out of 2 people who have been hospitalized for COVID have at least one chronic condition. Okay, 1 out of 4 people have diabetes, but you can also see there are other risk factors: heart disease, lung disease. Being a former or current smoker puts you a higher likelihood of having hospitalization compared to those who don't have that. And what we know in the U.S. is that roughly 2 out of 5 U.S. adults have at least one of the risk factors for more severe COVID infection. A couple of the other factors that haven't been spiked out on the left side of this exhibit are high blood pressure, as well as having a diagnosis of obesity or morbid obesity. And again, these conditions are disproportionately more prevalent among many of our minority ethnic groups. So as we move on to again, focus in on Utah, I thought it would be helpful to share this epidemic curve, right? This is where we plot the number of cases that have occurred over time, and that's depicted on the right side. And, you know, I think it's really important to kind of see that in that early time that, you know, this virus was starting to arrive into Utah, say from March through the end of May, we had a fairly steady rate of infection, and it was well below the 200 new cases a day. And in fact, some of that was early on. Our governor put in place some sort of, you know, stay-at-home recommendations. People were sort of sheltering in place. A lot of us were, you know, not leaving our homes, being very cautious about being exposed to others. And that was pretty effective in keeping the transmission down within the population. But really pretty much over, you know, Memorial Day weekend, you know, we started into the season of picnics and potlucks and celebrations and weddings and whatnot. You can really see over the summer, our rate of cases really did pick up in the state, and we saw the curve go down as many communities that were harder hit really took some more aggressive steps to, again, social distance, be mindful about hand washing, wearing masks, really doing, a great job in terms of cleaning and disinfection, what have you. But as you can see, since school started, really, we've got an uptick in cases, and it's not been uniform across the state. We know, for example, Utah County has been particularly hard hit in the last few weeks. Keeping in mind that, we are going to track this. This appears now for at least Utah to be kind of our second waves. Other states across the country really had a very definitive wave early on in March and April. We didn't really see that. We just sort of saw a steady state there, but I would submit that we're into our second wave here. Many communities are into their third. I did want to mention a little bit more about the kinds of cases in Utah, and on the left I've summarized for you that of the total roughly 65,000 cases in Utah, the majority of people were in the age group between age 25 to 44, followed by those in the age group age 15 to 24 at 26%. Keep in mind, today, the largest growing group in terms of infection is that age 15 to 24. Again, those are our teenagers and our college students, some of our essential workers that are out and about. And to a certain extent, I think it reflects the sort of sentiment, perhaps, that they're feeling less at risk for severe infection. But I want to underscore that these are individuals that can still get sick. But even more importantly, these are folks that often will come home, infect their parents, grandparents, relatives, aunts and uncles, co-workers potentially, who might have either a chronic condition or be more vulnerable or be elderly. In terms of our hospitalizations, the average age of hospitalization was age 53. However, 31% were over the age 65. And when we look at the fatalities or deaths related to COVID-19, you can see that it's really for that older set. Average age 73, with over 70% of deaths in Utah occurring among those who are 65 years. What I would say within Utah is that we are exceptional compared to some of our other neighboring states, in that overall our population is fairly healthy, and that our case fatality rate, if you will, is not quite as high as we've seen in other states and in other communities. So before I move into our immune response, I want to pause just a moment and ask Amy if you have any questions that have come in at this point before I move into our immune system.
No questions have come in yet. Please just feel free to send them, and I'll fill them out as we go.
Okay, great. Yes, I encourage everybody to use that chat feature there on the side. So I thought it would be helpful to talk about, how do we respond, to a virus? And this isn't necessarily unique to COVID-19 or the SARS-CoV-2, the virus that causes COVID-19, but, how do we respond? And some of it, I will say, age is a factor. The older we get, maybe the more sluggish our immune system might be. Maybe some of the reason why maybe the older people are disproportionately affected in terms of severity. But I wanted to kind of show you that there are sort of two phases of immune response. The first phase is our innate response. And keep in mind, this would include things like the lining of our respiratory tract, the mucus that we secrete to help kind of provide a barrier. Our skin is the first line of immune response, if you will. We also know that there are certain kinds of substances and cells that get called to duty, if you will, right out of the gate if we're exposed to a virus or any other kind of infectious agent, mold, dust, fungus, bacteria for that matter. And that's really our first line of defense to protect us from infection, right? So if I can call your attention to the left side of this exhibit, the first blue line that comes up is the innate response. Again, that's that initial wave to help keep us free from getting an infection established. And then let's say the virus has made its way into our body. You can see in the darker blue line, the bigger line here, if you will, in terms of the plot, that represents that the virus is in our body. We need it to enter into the human cells so it replicates. And prior to us becoming symptomatic, which is noted in the shaded area, we could potentially shed that virus or infectious to others. The next line of defense is our adaptive immune response. And this is largely a cellular response where there's certain types of cells in our body that are deployed. They include some messenger cells, T cells, B cells. You might have heard about these. They are called into play, if you will, to help us fight against that infection. That's represented in the kind of tan, yellowish line, if you will. The first antibodies that are produced by B cells, and those are the IgM antibodies, and that would be the dark kind of black line right there that comes followed a couple days later by the production of what we call IgG antibodies. And I bring this up because many of you heard about the COVID-19 antibody test or serology test. And so that suggests that, yes, you have been exposed to this at some point. We just don't know when. It could be that you were exposed, recently and you just are newly producing that antibody, or it could have been that you're exposed a while back. So it doesn't really tell us about your state of infection or your infectiousness, if you will, at the time that that test was determined. But I want to bring this up because many of us have been talking about the importance of COVID-19 tests, and it's important to share with you, what tests are available, why you might need a test, and what the different tests might be able to tell us. So there are essentially two general types of COVID-19 tests. There are the diagnostic tests, which diagnose whether or not you have the infection. And these are a molecular type test or an antigen test. And then there's those antibody tests, also known as serology tests. Those are the ones that say whether or not I have that IgG antibody. Did my body respond to that virus? What's important about these diagnostic tests is that they have different qualities. The molecular tests were the ones that were most widely available initially. These are the ones where you did the swab through the nose or even a saliva test. They detect virus in that specimen. Unfortunately, these tests take a little while to get back. I think, some labs are able to get that turnaround time within a few days. At the peak of testing, where we didn't have as much access to tests, in some labs it was taking a week, 10 days, right? It's a long time to be waiting to figure out, am I infected or not, right? But nonetheless, these are very sensitive or accurate tests that are very specific for COVID-19. And it's helpful to have a diagnostic test, right? That's to inform us about whether or not I need to isolate, keep away from others, and monitor for more severe symptoms, and also notify others that might have been exposed to me. Antigen tests have also become more available. There are only a few out on the market now, and we expect many more to be available in the coming months. And these are tests that are also diagnostic. They allow us to take that specimen, if you will, and it offers a much quicker turnaround time. It allows you perhaps to get a result within 15, 30 minutes, an hour. So the practical value is really that one would know their infection status, perhaps before you left the clinician office, to be able to then design a treatment plan, a game plan for your family, or establish whether or not you need to be isolated or whatnot. The challenge with the antigen tests, they're not quite as sensitive as the molecular tests. Their ability to detect this virus, the cutoff value, if you will, is a little bit higher. So it's quite possible someone might have symptoms that really look like COVID, but they have a negative antigen test. And in that case, the clinician would typically order a molecular test to make sure that it wasn't COVID-19. But nonetheless, for those that are positive with the antigen test, great information to know out of the gate, again, to be able to take those steps to not only care for oneself, but protect others. The antibody tests are really useful if we're looking to see how widespread this infection might have become within a population. Perhaps it's within your workforce, maybe it's within a school, a classroom, a certain skilled nursing facility, right? These tests are often helpful to know what proportion of the population may have been, say, infected infected, potentially exposed to the virus. And these are very important right now as we've seen a lot of vaccine trials for COVID-19 to determine how effective the vaccine might have been in inducing that immunologic response for the individual to produce an antibody that would be effective in preventing infection in the future. So again, a little bit about these tests, super helpful to be thinking about this. And I fully suspect as the fall, we're coming to the fall now, the latter part of the year, we'll be able to see and have available more of these diagnostic tests, which are going to help us contain this infection. The other reason we want to know about your infection status is to be able to shut this virus down, not let it propagate through the population. And I want to quickly show you sort of what happens in a population when you're exposed to infection like SARS-CoV-2, the virus that causes COVID-19. And this is to show you that in an unexposed population or a population that is not immune to this virus, the person in red, how many other people would that person likely spread that infection to if we didn't take any precautions? And the answer is roughly 2 to 3 for the SARS-CoV-2 virus. At least that's what we understand. And again, a population that is not immune. So as you can see, that one person then, say, spreads it to 3, and then those 3 people would go on to spread it to others. This is called the basic reproduction rate or basic reproduction number of a pathogen in a population when no one is immune. Now, of course, we know we can take some steps to contain it, even though we don't have a vaccine yet, by preventing likelihood of transmission. And so the next picture is to really show you that it's important to identify contacts, right? So that infected person, say, exposed themselves to those 3 other persons who didn't have immunity. We want those contacts to quarantine. We want them to stay out of circulation for a period of up to 14 days. That's the outside of the incubation period to make sure they're not spreading it to anyone else. Of course, all the while, they'll be monitoring their symptoms as well. But the notion here is that we want to shut in the virus so it does not propagate across the population. We can also defend from propagation from the contacts by proactively making sure people are taking steps to prevent the inhalation or exposure, being in close proximity to infected persons, right? So that the likelihood of an infected person coming in contact with someone who is not immune is reduced. And that's really the basis for the recommendations for disease prevention. I like to share this idea of density, distance, and duration. I think it's easy to remember, but it really is what is behind the recommendations for good hand washing, wearing cloth face covering, and staying physically distant. And density is really about being mindful of who you're around. If you're around 10, 20, 30 people or a big crowd, you're more likely to be exposed to those respiratory secretions and potentially secretions for someone who's infected with this virus. When we stay physically distant, the farther apart we are, the less likely that an infected person could spread those droplets to you, where you would then inhale or ingest them. And duration means limiting the time that you're with others in either close proximity or in a closed space, right? To a period of, just a few minutes. If you're at a meeting or a ball game or something in a closed, say, gym, sitting right next to a number of people, and that's 2 hours, that would be a significant duration. In general, we define a contact of someone who's been exposed to infected person within 3 feet for a period of 15 minutes or more. And unless you're a healthcare provider, in which case it could just be in much closer proximity, but maybe not wearing personal protective equipment. But there are a number of studies that come out, even since the pandemic began, still coming out, to look at the effectiveness of these strategies. Nothing is perfect. Keep in mind that nothing is perfect. Masks are only good if you wear them. And that means making sure they cover your nose, they cover your mouth, that you're not contaminating yourself by touching the outside and then rubbing your eyes or taking them on and off improperly. We'd also want to make sure that they're at least double layer in thickness, right? And they're properly laundered. There are a number of kind of styles out there right now. I submit it's important to wear one, make sure it's fitted correctly. And a couple of ways you can check to see if it's probably doing you any good would be hold it up to the light. If you can see right through it, it's probably not blocking your secretions from coming out. You shouldn't be able to blow air through it, right? That would be another, way to check. You want to make sure that it is properly containing your own secretions, so you're effectively protecting you from another person. Conversely, that person and wearing the mask would be protecting them from you. The other data that are coming out is to show that, grossly, the external part could potentially filter out secretions that might be coming to you. The only mask I would say that I'd be cautious about are the ones that have the one-way exhalation valve. That's essentially concentrating your breath, if you will, and blowing it out, it's sort of into the face or around the environment that you're in. So we may have some questions about that, but I thought it was worthwhile to spend a little time talking about why that's important, again, to contain this infection so it's not spreading within our community. So we've had a new culture, right? 2020 has been quite a year. We've all talked about the importance of hand washing. We've known this, right? And you've known it with your kids as they've gone off to school, whether it be daycare or just starting into primary school. Hand washing was super important. Wearing a mask has emerged as of great importance, and being physically distanced, right? The recommendation is 6 feet, and then essentially quarantining if you're exposed or isolating if you're infected. And the last bit is a sneeze etiquette, right? Making sure that you're coughing into your sleeve, into your shirt, making sure you're using a tissue, disposing it, and then washing your hand. And so it's, again, important because this is a basic public health approach, not only to help prevent the spread of COVID-19, but I'd submit it's helping to reduce the spread of colds. And as we come up on the flu season, flu infection or the spread of flu viruses as well. So let's talk a little bit about ways to prevent and treat COVID-19. Optimize your health. I talked to you earlier about the risk factors that go along with more severe infection. So if you do need to lose a little weight, now's the time to do it. Time to get fit, stay physically active. If you use tobacco products, stop using them. Paying attention not only to diet and exercise, but getting plenty of rest. Adequate sleep is really important. It helps fortify our immune system, as well as a balanced diet. And I would be remiss not to mention getting the recommended preventive services, including flu shots this fall, right? Flu shots can help prevent more severe flu illness. And as we come on to flu season this year, I think this kind of co-occurring infection risk could be very real. Not only do we not know exactly the impact of 2 infections at one time, we don't want to overwhelm our healthcare system, and flu shots have been shown to reduce the need for hospital visits, emergency department visits. It reduces death. It also, won't congest your, kind of gum up your urgent cares, pediatric clinics, primary care clinics. Less or fewer lost work days are all related to getting a flu shot. I also think it's important to pay attention to those chronic illnesses, get that blood sugar under control, blood pressure under control. A lot of people have actually, maybe postponed their primary care follow-up visits, or maybe haven't gotten their medications filled in a timely manner, appropriately concerned that they didn't want to get exposed, say, in the healthcare setting. But as Spencer said, telehealth is here, and it's really awesome. It offers the ability to see your clinician, maybe in the comfort of your own home, but really allows that exchange to be more timely, so you can really attend not only to those chronic conditions that need to be managed, maybe medications adjusted, but also attend to some of those other preventive care services that would be recommended. Now, moving on to treatment for COVID-19, corticosteroids, been around for a long time as one of our medications or drugs available to treat illness, have been found to be very helpful for those who have severe COVID infection, those who've been admitted to a hospital. So that's something that's readily available, and these are not expensive. These are not costly medications. We are also have seen the potential role of convalescent plasma. This would be plasma or blood taken and filtered that really just leaves the antibody part, or what part of the blood that has the antibodies in it, from individuals who've been infected with COVID-19. And then this plasma would be infused into a COVID-19 patient to help that person fight the infection, to reduce the likelihood of more severe or poor outcome. There are a number of monoclonal antibodies that are being explored. These would be antibodies that are made in a lab. They're synthetically produced, if you will. A number of clinical trials are underway for those. And we've also seen antiviral therapies that have been tried for those who have more severe illness, either are already hospitalized, maybe in intensive care, potentially those who are also on mechanical ventilation, to help stop or shorten the course of the illness and to prevent more severe outcome or death. Vaccines are what I'm going to really close my comments on, to say that there are 9 vaccines that are currently in what we call phase 3 clinical trials. It is the 3rd phase of vaccine development that occurs to determine whether that vaccine candidate is not only effective in preventing infection or reducing the severity of infection, but is safe to use in the population, doesn't cause other problems that we, hadn't anticipated. Of these 9, it looks like about 3 are emerging to have sort of the most robust data. And when I say most robust data, they are doing these trials on, 50,000 roughly, people. And it's important to be thinking about that, because once we identify a vaccine that appears to be effective and is safe, there's the whole ramp up, right? The manufacturing process that comes into play. And what we've entered into is what's called at-risk manufacturing. Currently today, manufacturers across the globe right now are developing these vaccines, which often take, a number of steps, have to be done in sterile circumstances, often require temperature controls, et cetera. But we are producing many of these vaccine candidates right now with the hope that one will be approved for use in the public, in the population, to prevent, again, or reduce the likelihood of severe COVID-19 infection. But once we get to that point, as you can imagine, we now need to also figure out how we're going to get it into people, right? So flu shots are about the best example we have in how we provide mass immunization. And so in this year, especially as we come up on flu season, I think many of our healthcare providers or public health agencies, others that traditionally provide flu shots, are thinking about that process, because if we want to deploy mass vaccination against COVID-19, we're going to need to have a process in place to do so. So I'm going to pause right now because I've really covered a lot of ground, and just ask Amy, do you have any questions that have come in or other thoughts or comments that I can answer at this time?
Yep, it looks like we've had a couple come in. So this first one is 2 parts. If you have an employee who has tested positive and is quarantined at home, how do you know when it's safe for them to return to work? And additionally, should they be retested before they can return?
Excellent. It's a terrific question. The CDC has offered sort of 2 ways to sort of monitor or determine whether someone is ready to come back to work. The first is based on symptoms. So if you've had an infected employee, you'd want that individual to go home and remain out of commission for at least 10 days since the onset of symptoms, right? So at least 10 days for the onset of symptoms, and not have had a fever for at least 2 days before coming back to work. So that's essentially, if you think about it, most people can shed virus about 2 days before they become symptomatic. Most people have their virus detectable, if you will, in their bloodstream for the first 7 days after they become symptomatic. So if you stay 10 days out after you get symptomatic and you haven't had a fever for a couple days, that's one method or strategy to be able to determine, is a person ready to go back to work. The other, and the other is often used in the healthcare setting, but could be used in other settings, is the diagnostic testing method. And that method is that you must have 2 COVID-19 diagnostic tests that are negative, conducted at least 24 hours apart. So let's say get tested at day 9 and it's negative, and then day 10 and it's negative. So that would be another way to be able to determine, is your employee ready to come back to work? Other questions?
Yeah, the last one we have so far is, is there a concern that the virus will mutate before a vaccine is available?
That's a great question. So unlike flu viruses that we know really do constantly change, right? And many of you know, we get an annual flu shot, and that flu shot, for example, this year, whether it's a trivalent with 3 different flu viruses or a quadrivalent with 4 different flu viruses, that the manufacturers make that flu vaccine depending on what is the most likely strain of virus to be circulating in North America. And every year it changes, and it did change a little bit this year based on what studies were conducted to determine the most likely strain that would be circulating in our population. For COVID-19, the SARS-CoV-2 virus, we don't know exactly, right? We don't have enough history with this yet to understand how fast it might be changing. However, the reports available so far have suggested that when a vaccine becomes available, it is probably pretty likely we would need a 2-shot series or 2-dose series. A first one maybe separated by a month or 2 and then get the second one. But what we don't yet know, is it changing fast enough in a meaningful way so that it'd be like the flu shot, potentially, where in future years, if it becomes more seasonal, which right now it hasn't really been, would you need an annual vaccine or a booster or a vaccine that perhaps has been modified in some way to keep up with the most prevalent strain? Breaking news prior to our meeting today was that there was a lab that has released some data on mutations of this virus. It hasn't been peer reviewed yet, but the implication is that the virus may have become potentially more contagious, but perhaps not as virulent or not as severe, right? And if you're a virus, you don't want to be a virus that kills all your hosts, right? You want to be a virus that you need it because you need a human, let's say, to replicate, right? You don't want it to be too lethal. So this may be part of the natural history. We just simply don't know yet. Fortunately, there are many, many bright folks in all corners of the earth right now really studying the nature of this virus, and in fact, how we can design a vaccine that perhaps can be more specific to parts of it that are conserved. Conserved means that aren't changing so quickly and still induce that really robust immune response. I hope that was helpful. I do want to just mention a couple kind of takeaways before I entertain any additional questions, and that's that we're all living through history, right? I try to keep up to speed on this. It seems like this information evolves every day, but we do still know a lot about it, right? We still know basically how it's transmitted, how to protect ourselves and our loved ones, making sure to take those steps, be thoughtful. I think in a way we've all become much more familiar with public health and the importance of it. And keeping in mind that, there's some waxing and waning, and even across our state, right? We've seen some areas get initially hit more harder than others. And then again, others that maybe weren't as initially hit as hard, we're seeing more cases. I think this is going to be how it goes for a while. And so being able to be flexible, to sort of be creative, if you will, and being able to adapt are going to be really important qualities as we move through this. And then lastly, being whatever's normal, has changed for all of us. We used to early on kind of talk about when are we going to get back to normal? I think we need to really embrace that we are all in this together, riding into sort of a future, and we're defining to a certain extent what the norm will be. And during that time, I think it's really important that not only we're patient with each other, but we're kind to each other. And just want to give a call out that many of us have had friends, family, loved ones, coworkers affected by this. Some deaths, some severely ill, some that are just grieving the loss of what was usual, milestones in our lives. And it's important that we, really have that care and concern for each other as we move through this. And we will be successful. And it is probably going to look different, but I think that we'll only be successful if we're working together. So with that, Amy, I'm going to turn it back to see if there's any other questions or comments that might be useful to share.
We have a couple more so far. One of them is, do you know how the virus is affecting individuals 15 and younger?
Yeah, that's a great question. So as I mentioned earlier, that this virus seems to disproportionately affect older persons. The older you are, the more likely you're having severe illness. And if you have these co-occurring conditions, obesity, hypertension, lung disease, diabetes, you're more likely to have severe illness. The age set that we really have not seen a high level of severe illness are those under 15-year-olds. However, it appears they can carry the virus, transmit the virus. They just don't seem to be manifesting the same degree of severity and illness, with the exception of a rare condition. We've called it the multi-system inflammatory syndrome. Fortunately rare. We've had 3 cases in Utah. These are as a condition that looks a little bit like toxic shock syndrome, looks a little bit like what we used to call Kawasaki syndrome, which affects all of the organ systems and is life-threatening. And unfortunately, there have been some deaths reported across the world of kiddos that have had that. So we're learning a little bit more about, what it is about younger people that perhaps they don't get as severely ill. And this is a little bit different than the flu. Flu deaths, although predominantly occurring in older people, about 10% of flu deaths do still occur among kids 5 years and younger. So it's important to really think about what is it that's different about this virus and how it behaves in younger people and younger children that is different from the flu.
Okay, and then there's actually a follow-up regarding the questions on infected employees. If
Sure.
they were asymptomatic when tested positive and have since only been fatigued with no fever, is it better to do the 2 negative tests approach for them to return?
Well, that's a great question. I have not seen any data on that, but an asymptomatic confirmed case of COVID-19, I would go ahead and use that 14-day period, because that is the full period. Some people may become symptomatic later, right? So it's hard to know in that case. One question I would ask is, why was an what was the circumstances of that, test? Usually it's an exposure or contact, right? So to be safe, 12 to 14 days would probably be sufficient, particularly if they were afebrile with no other symptoms, to be able to go back to work.
And then for the vaccine, are there individuals or diagnosis where a person would be advised not to have the vaccine?
It's an excellent question. We're still waiting to hear which vaccine candidate will be ultimately approved, or at least given emergency use authorization by the Food and Drug Administration. And at this time, we don't know specifically what vehicle, meaning the type of vaccine that is going to be approved, and what sort of maybe requirements or limitations it might have. For example, we know that people who have egg allergies can't take the flu vaccine that is made through egg culture, right? Fortunately, there are flu vaccines that are cell developed or even made in the lab. So people who have that allergy could take those vaccines. We also know that older people don't have as robust immune responses. So for flu vaccine, we have a higher dose flu vaccine available this year to give those elderly persons. What we don't yet know is which COVID-19 vaccine will be approved, and then when it is approved, what are the sort of characteristics of it, and what might be the limitations in terms of who may or may not be appropriate for it.
I think that is all the questions so far. One question that I just was thinking of is, I know that there's been a lot of talk of how important it is this year to get flu vaccines. Of course, it's important every year. When is the best time to go get your vaccine?
That's a great question, Amy. Yeah, I think it's on everybody's mind because it's fall, right? And we're into, September. So the best time is, September, October is usually what's recommended. The sort of average flu season, you'll see flu cases starting to arrive in October. Usually it peaks between December and February. What I will tell you is there's very little influenza activity right now circulating in the United States. And that is a little bit unusual. You expect to see a little bit more activity in terms of this virus. But I will just say in the Southern Hemisphere during their summer, our winter just passed, there were, their winter, excuse me, our summer just passed. There was very little flu activity in the Southern Hemisphere. So maybe some of these steps that we're taking, the kind of physical distancing, the hand washing, the mask wearing, what have you, have actually helped to decrease the transmission of influenza and other respiratory illnesses. So if, I used to say, now's a good time to get it if it's convenient. If you happen to be going into your doctor's office, you're into Walgreens, you've got an event, there's going to be all kinds of, public vaccine events, even drive-through events this fall. I think it's important to get one and keep in mind that sometimes it's just a matter of, oh, I have, a few extra minutes today. Let me pop down here and get one while I can. So now October's fine. It's really, just be sure to get one.
Okay, that's all the questions, unless anybody has one last one they want to pop in the question box. Then, Spencer, are we turning it back to you?
Well, thank you so much. Yes, I appreciate all the questions, Amy, and I will certainly be available if anybody does have follow-up questions. But Spencer, we appreciate the opportunity to join you today.
Oh, thank you. It has been a pleasure to learn from your perspective and experience about COVID-19. So the information has been extremely helpful. So thank you, thank you. And Amy Jenkins, thank you so much for fielding questions and facilitating some of those for us.
Absolutely.
Well, we want to thank all who have participated today and all that's gone on the back end from our team as well as your team over at Regions to make this possible. So thank you very much. We're grateful for the blessing of technology and the opportunity that we have to gather virtually. We'd also like to remind you that this will be available, this video recording will be available in about a week and a half for you to view, or if you have employees or individuals that haven't been able to see this, they will have that opportunity moving forward. And then in addition to that, we would like to remind you that we have one more event next Wednesday at 10 o'clock. The topic will be talent acquisition in today's market. And we're excited to look forward to that and the conclusion of our webinar series. So thank you all. We appreciate it and have a wonderful week.